Hi. I've got the chat pulled up. Can you hear me all right? Oh, my volume would help probably. Say something?
Yeah, I can hear you.
Okay, good. I had my whole computer muted.
Oh.
I don't like the emails blinging through. Bling, bling, here I am. Bling, bling, here I am. So I just have it. All right, so we got Valeria. It's usually a small group with you guys, huh?
Mm-hmm.
Okay. So we'll probably wait till about. This is awkward, just a tiny bit.
Are you going to go over the sheets that you sent us?
I will address that the last couple minutes at the end.
Okay.
I know it seems like a bunch, but see, there's an email coming through. Dang it. How do I make those be quiet?
I could hear you even though you muted your computer. Try it again.
Well, there we go. It's just it's blinging emails at me. So it gives me a little chime. I don't know how to turn that off. So whatever. There's some little bells and whistles that happen. That'll be okay. Wonder. It's a little different setup than what I used with when Lori and Ann and I were on, because it's on a laptop and not an iPad, so the formatting's a little different.
Oh, okay.
Little bit of a learning curve. I think we're all learning as we do this.
Yeah, really.
Had to get real tech savvy real quick.
Mm-hmm. Has the governor opened the schools?
I don't think the public schools, he's supposed to talk today sometime. So
Oh, okay.
the news said he would address sometime, and the last time I tuned in for his address, it was supposed to be at 3 and he didn't come on until like 4:45. So
Yeah.
sometime today, he will say something. Hopefully. All right, just a couple more minutes and then we'll get started. And I think we'll talk about the daily sheets to start, just so I don't run out of time.
Okay.
Hi, Lauren. Oh, she's gone. Let's see. Give her a minute more, 'cause somebody just popped in and popped back out again.
Okay.
There she is. Okay. No video, no. Okay. Okay. 5 after. So we'll jump in now. The first thing I wanted to address is we got a couple emails about the daily sheets. Those are how we are going through, and as you turn in assignments, there are checklists to where if you look at the sheet, it says it's got time equated with it. So we say, okay, they did this, give them a check, it equates to time, give them a check. And so we go through that to make sure that everything is being accomplished. We decided to send them out because there's some assignments on there that don't fit into the format of MindTap. So like the review questions that are at the end of the chapter, or section, as it is for like skeletal and all those, that format didn't fit into MindTap, but we needed to have you do it because it's helpful it's a good review over the material. So when you're looking at it, a lot of it will correlate with all the listing things you're seeing in MindTap. There will be a few additional assignments that are fill-in review questions and things like that. If you're not sure if two things are matching up, just shoot us an email real quick and be like, are these two the same thing or is this something extra? And we'll figure it out for you as fast as we can. We're trying to be very amiable because it is confusing. It's a lot of back and forth with email, and there's a lot of bells and whistles to decipher in MindTap, and we know it can be confusing and maybe even a little overwhelming, but the idea behind those sheets is just to keep you kind of on track with this is all the stuff you need to do. Everything in MindTap will count itself and we'll have that there, and then your physical assignments, we have this here to turn in. Does that clear it up a little bit?
Yeah, there's a section on it that says you have to clock in.
Clock in.
Yeah, it says clock in to check your hours and clock out for breaks.
I'm not sure if that pertains to us, because they were formatted from the Cosmo program's timesheets, so it may be residual from their format
Okay.
on our sheet. But I will shoot an email today and Hawkins for massage people. I'll figure out what that means. I'm pretty sure it's just residual from Cosmo's format,
Okay.
though. Any more questions? Anybody in chat? I've got the chat open live so I can actually see it. Took me a second to find it, but it's up there. Cool. For those of you who don't know me, my name is Christina. I've been a massage therapist for 12 years now. Been teaching here at Sun State since October, and I really love massage, and I hope you guys will too. So let's go into the skeletal system. We're going to be on page 120 in chapter 5, and you'll need a highlighter and to take some notes as we go. If you look on page 120, I'm going to scooch you guys back a little. There we go. If you look on page 120, you're going to see review of the skeletal system. So what learning objectives, and this lays out what we hope you will learn as you read this section. So we have described the functions of the skeletal system, differentiate between the axial skeleton and the appendicular skeleton, describe the functional and structural classifications of joints, and describe 5 types of movable joints. So here we're really discussing the skeletal system, not specifically learning specific bones of the body. You'll get more into that when you do the section we call hip, leg, and thigh, or face, torso, spine, or arm and shoulder, where you will learn all the musculature, all the bony landmarks, all the joints, protuberances, all of these pieces of those areas as a whole. So the first thing I want you to, skeletal system is a bony framework of the body. It is composed of bones, cartilage, and ligaments. Lorian's checking on me. I'm not Zoom efficient, I guess. The skeletal system is the bony framework. If we didn't have bones and we were just skin and muscle, we'd be blobs on the floor. So we need some scaffolding to pick us up and keep us upright. Something for muscles to pull on to give us movement. All right? The functions of the skeletal system, I want you to highlight numbers 1, 2, 3, 4, and 5, and I will read them. To offer a framework that supports the body's structure and gives shape to the body. To protect delicate internal organs and tissues. To provide attachments for muscles and act as levers in conjunction with muscles to produce movement. To manufacture blood cells in red bone marrow, and to store minerals such as calcium, phosphate, calcium carbonate, magnesium, and sodium. So it's not only the scaffolding of the body, it performs other functions as well. If you didn't have some bones in place, like think of your breastbone, your sternum, you know, your heart and lungs with your sternum and ribs, without your sternums and ribs, would be very, very vulnerable. I mean, I don't think we would have made it if we didn't have them as a species. So moving on to the composition of bones. Bone is the hardest structure in the body other than dentin, and that's the dense hard tissue that forms the body of a tooth. So, teeth are harder. That's a highlight there. So in lots of times when you think of, you see a skeleton in a movie and he's all dried up in the corner and he's really solid bone-wise. I mean, he's missing some pieces. We think of bones as solid pieces, but in all reality, if you look on page 121, we see that it's really got a lot more than just what meets the eye when you deteriorate the flesh and muscle off the body. So bone is composed of approximately 1/3 animal matter and 2/3 mineral matter. Remember we talked about storing minerals. or earthly matter. The animal or organic matter consists of bone cells called osteocytes. And now if we go back to like our medical terminology, we know that osteo has to do with bone. Cyte, whenever we see that, that has to do with a certain type of cell, whatever's talking about at the beginning of the word. That's an osteocyte. Within that, we also have blood vessels, connective tissue, and marrow. And the mineral or the inorganic matter consists mainly of calcium phosphate and calcium carbonate. Right? So I want you to highlight the word osteocyte as well as calcium phosphate and calcium carbonate. Those are important terms to remember. And so if you look at figure 529, you're going to see the bone forms or shapes. I think it's easier to call them shapes. It's just what I like. And you will see flat bones, such as those of the skull, pelvis, and ribs, or costals. Now you may think that a costal or rib could function as a long bone, but if you were to take a rib out, you can actually see that it is flatter, long flat. But we don't have that section. We have long or flat. So we have long bones, and those are going to be legs, arms, fingers, toes. And then we have short bones, such as those in carpals and tarsals. Irregular bones, such as vertebrae. If we look at vertebrae, you see this portion of the board? Okay. If we look at vertebrae, now I'm not an artist. Kind of a funky shaped bone. This is as if we were looking down the vertebrae and the spinal cord would go here, right? But I would say that's irregular. And then we have sesamoid bones, such as the patella. All right. And go ahead and highlight those bullets there too. So let's get more into long bones. And this is going to go with figure 530. A lot of the pieces that we're talking about here are located in that picture, or illustration rather. Now, I want you to start highlighting. A typical long bone has enlarged areas on the ends called epiphyses, which articulate with other bones. The end surface of the epiphysis is covered with a layer of hyaline cartilage called articular cartilage. Articulate cartilage provides a smooth, shock-absorbing surface where the two bones meet and form a joint. The shaft of the bone between the epiphysis is the diaphysis. I want you to know those terms and know the difference between those terms. The epiphysis, we see proximal and distal. We go back to our medical terminology. We know that distal is further from the medial point. Proximal is closer to, right? That kind of tells you where it lives. If you just take a second and go think back to your medical terminology, the body tells you in its name where everything lives. Just takes a split second of dissecting the words. And so that hyaline cartilage that covers the epiphysis, we're calling articular cartilage. It's where things articulate together, meaning a movement, so that we don't have bone on bone. Because as you probably hear from older people that have deteriorating hyaline cartilage, or like extreme athletes that have been competing for a long time in whatever sport, when you get bone on bone contact, it's very painful. So if we didn't have these buffers, we'd be hurting. All right, so except for the articular cartilage, the bone is covered by the periosteum. So we go back to our medical terminology. Peri means a covering, osteo, back to bone. And highlight here, the periosteum is a fibrous membrane, the functions of which is to protect the bone and serve as attachment for tendons and ligaments. So instead of just having little portions where things can attach, the periosteum is a coating of the bone where we can have really strong attachments between ligaments and tendons to their other structures. Right? In the diaphysis, it also contains an abundance of nerves, blood, lymph vessels, and is essential to bone nutrition and repair. Beneath the periosteum, the walls of the diaphysis are composed of compact bone tissue, and you can see that demonstrated halfway up the diagram, middle there. Highlight this. Compact bone tissue forms the hard bone found in the shafts of long bones and along the outside of flat bones. This tissue is strong and rigid. And continue highlighting. The inner portion of the bone is made up mostly of cancellous bone, also called spongy bone, which consists of irregular shaped spaces defined by thin bony plates, turn to page 122, called I always struggle with this one, trabeculae. This provides a lightweight yet surprisingly strong interior structure to the bones. The cancellous bone tissue in the flat bones and at the end of long bones is filled with red bone marrow and is the site of production for blood cells. The medullary cavity is the hollow chamber formed at the shaft of the long bones and is filled with yellow bone marrow. End highlight. So let's backtrack a little bit and talk about that. So we see cancellous bone, not cancerous, cancellous. And all that means is spongy bone. And if you look on your diagram on 121, you see how it's kind of like a netting almost, with little hollow pieces. And if you were to look at that structurally when it comes to architecture, if we were to take this same kind of model and create a dome using this same shape, that dome would be dang near indestructible because of the weight distribution from the top to the sides. All of those little walls give it strength. So that's what gives us the ability to flex and move within bone a little bit. Bones do break, but it's also strong and rigid to be able to support us up and allow us to do extreme activities. I don't do extreme activities. It's too much. All right, so let's go back over to page 122. And I want to talk about marrow. So marrow is the connective tissue filling the cavities of bones. Its function is largely concerned with the formation of red and white blood cells. There are two types of bone marrow, red and yellow. Red marrow functions in the production of red and white blood cells and platelets. Go ahead and highlight that sentence there. Red bone marrow functions in the production of red and white blood cells and platelets. Stop highlighting. It occupies nearly all the bone cavities of the newborn. However, in the adult, it is found in the bone spaces of the skull and ribs, sternum, vertebrae, and pelvis. Right. Begin highlighting. Yellow marrow is the result of inactive blood-producing cells filling with fatty material and is located in the medullary cavity of long bones. Right. So if we can think about adipose tissue, usually represented as yellow, like an orangey yellow, whenever you see it in a diagram, you can attribute that to the yellow bone marrow. It's a fatty substance within that marrow. But in cases of severe blood loss, and the body is like in emergency mode, yellow marrow will change back to red marrow because they need to start producing cells. You know, it's emergency emergency mode, all hands on deck, let's pump out some cells. Which I think is pretty cool. The body's got a lot of safety mechanisms in place. Kind of wants to keep on living. All right, so bone nutrition. Go ahead and start highlighting. Bone receives its nourishment through a highly organized system of blood vessels. So we have a blood supply to our bones. They're not as we think them as just these dry sticks hanging out in our body. Blood vessels known as capillaries that make their way through the periosteum and into the interior of bones. So they've got to have a live supply. And highlight. Bone marrow also aids in the nutrition of bones. Start highlighting. For proper growth and hardening of bony structures, the diet should contain an adequate amount of calcium, phosphorus, and vitamin D. Because we need all of those to work in congruence with each other to mineralize the bones. Otherwise, we get soft bones. Anybody have any questions so far? No. Bones are fun. Oh. Lauren, it popped over to you. Are you going to chime in?
Oh, I just said no, I didn't have any questions.
Oh, okay. It just all of a sudden moved. I was freaked out. Lorianne said the stream crashed on her yesterday, and I'm just like, oh, I hope that doesn't happen. Smooth sailing from here. Anyway, continuing on. So knowing the skeleton as a whole, and that's what this section is all about. Learning its function and structure and pieces of it, not so much in an in-depth sense as some of the trail guide stuff that will go on later in the program. So I want you to highlight the skeleton is divided into two main parts. We have our axial skeleton. We have our appendicular skeleton. Now, when you think of axial, the way I remembered it is if you think of a globe, oh, that's a pretty good circle, right? And when the globe is turning, the stick through the center was its axis, right? So if we think of that same premise, the axial skeleton is made up of the skull, spine, and ribs. Right? So it's the inner portion of the skeleton. Right? Then we have appendicular skeleton. Now the word you'll see in appendicular is appendage. Appendages. All right, and so the appendicular skeleton is going to have to do with the bones of the shoulder, upper extremities, hips, and lower extremities. So the parts that come out from the middle. So go ahead and highlight that first sentence there, and then also the last sentence of that little section there. The name appendicular identifies these parts as appendages or extensions of the axis or axial skeleton. All right. In the human adult, the skeleton consists of 206 bones, and they are distributed as follows. Numbers in parentheses indicate the number of bones. So go ahead and highlight the cranium. It forms a protective structure for the brain. See, so there it is, doing one of its functions, protection. We need something strong to keep our brain safe because we kind of need it. Performing a few functions. All right, so the cranium has 8 bones. We have our frontal, parietal, occipital, temporal, sphenoid, ethmoid. Gives us 8. All right, So we'll see next to parietal, next to temporal, we see 2. That means on either side of the head. All right, go ahead and highlight those. This is not a highlight, but on the face, we have 14 bones. And we have to have lots of bones because we make lots of movements, so we've got to have things to pull on to create those movements with our muscles, right? Also, I wag my jaw a lot, so I need pieces to do it. So in the face, there's 14, forms the structure of the eyes, nose, cheeks, mouth, and jaw. We have the maxilla, 2, palatine, 2, zygomatic, 2, lacrimal, 2, nasal, 2, vomer, 1. Inferior nasal concha, or concha, depends on how you want to say it. It's anatomy. You can pretty much, if you have most of the letters there, you can say it how you want. I won't correct it. You have 2 of those and the mandible. All right, so this is a highlight here, and I'm sure you've heard of the ear bones, right? Those are how part of the function of our hearing works, is how the bones move in our head. And we have 6 of them. They form the internal structure of the ear. We have the malleus, the incus, and the stapes. We have 2 of each, set of 3 in each ear. Right? Then we have our hyoid bone. Right? Hyoid, you're going to see it on men a little bit more prominently than women. It's not very comfortable to palpate, but general area, 1. Right? And it supports the base of the tongue. Then we have our vertebral column. It forms the spinal column, which supports the head, trunk, protects the spinal cord, and provides attachment for ribs, cervical vertebrae, there's 7. Thoracic vertebrae, there's 12. Lumbar vertebrae, there's 5. Nope, sorry. Yes, sorry, my brain. Sacrum, 1, coccyx, 1. So a good way to remember these we have breakfast, lunch, and dinner. We have 7, 12, and 5. We eat breakfast at 7, we have lunch at 12, we eat dinner at 5. Make sure I'm spelling correctly, yes. Right? Now to remember sacrum and coccyx, I just say 1 minute later, you have 1 snack after dinner. So 1 minute later, you have 1 snack after dinner. That's just, I like mnemonics, they help me remember. Although I usually have more than 1 snack. All right, but if we add all those numbers up, that gives us 26, the number represented here. And then we have the thoracic cage. In the thoracic cage, we have ribs, or costals, as they're known anatomically. There's 24 of them, all right? So we got 1 more bone to add here. We have the sternum. Sternum serves as an attachment for the ribs at the front of the chest. And you'll see, if you go to page 122, where the ribs attach to the sternum is with more cartilaginous fibers. So it's not so much you know, like a hinge joint, like it's not a lot of movement, but there is flexion. So when we, our ribs can expand and move with our lung function, right? when you're puffed from going up 3 flights of stairs. Woo. Right? The ribs themselves form a protective cage for the lungs and heart, right? We have this cage that protects all of these vital organs, right? So that's the meat and potatoes of the axial skeleton. So if we move on to the appendicular skeleton. The appendicular skeleton consists of upper extremities, and there are 64 of them, right? Not 64 extremities, 64 bones, right? We have the clavicle, scapula, humerus, ulna, radius, carpals, 16 of those, metacarpals, 10 of those, and phalanges, 28. Within the lower extremities, there's 66 bones. So we have the pelvis, which is a fusion of 3 bones. We have ischium, pubis, and ilium. Right? Then we have our femur, patella, tibia, fibula, an L, not fibia, fibula, tarsals, metatarsals, and phalanges. Go ahead and highlight upper and lower extremities. And I also want to make sure that you have the ear bones highlighted as well as the cranium. Oh. We good? Oh, what happened? There we go. Okay. So the next section that we're coming up on is called bony landmarks. Now, we're not going to go too in-depthly into this because, like I said earlier, when you get into hip, leg, and thigh, face, torso, and spine, and arm and shoulder, learning those sections individually, you will intimately learn all of these bony landmarks. Now, it's not going to be a bad idea to familiarize yourself with the term because you'll be exposed to them later. But as for this lesson today, it's not going to be in-depth lesson or knowledge. But let's go ahead and talk about some of the words, pronouncing some of the words. Some of them can be kind of difficult. So words that describe bony landmarks. A condyle. A condyle is a rounded, knuckle-like prominence, usually at the point of articulation. An epicondyle, a small bumper rise near a condyle. All right? Crest, that's a ridge. A foramen, a hole. A fossa, it's a depression or a hollow, so just like a little scoop out of a bone for something to rest in. A facet, a small, flat articulating surface. Right? A head, a rounded articulating process at the end of a bone. A line, a less prominent ridge of a bone than a crest. Right? Now everybody wants to say meatus for this one, but it is meatus. And it is a tube-like passage. And then we have a process, a bony prominence or projection, something that poked out. A sinus or an antrum, a cavity within the bone. Then we have a spine. Now this doesn't just pertain to your spine. There are spines of certain bones. And that is a sharp, slender projection. Then we have a trochanter, a large process for muscle attachment. Then we have a tubercle, a small rounded process, and a tuberosity, a large rounded process. Now those terms we will go more in depthly, and I promise you will know them intimately. You will have flashcards of them. They will be great friends. And you'll kill it at trivia with them. So the next couple pages are going to be diagrams, just pointing out and labeling all of these bones and bony landmarks. We're just going to go ahead and kind of zoom over those. And I want to come to the section that says joints. Good? Okay. So our learning objective here is to describe the functional and structural classifications of joints. Not all created equal. So the bones of the skeleton are connected at different parts of their surfaces, such connections are called joints or articulations. Go ahead and highlight this. Joints are classified according to the amount of motion that they permit. Right? So when we see synarthrotic, such as those of the skull. So if we think about an infant, when they are born, the bones of the skull aren't yet fused together. When we reach adulthood, 22-ish, is when those bones finally fuse properly and fully. We don't have that movable skull anymore. The sutures that bring those two together are virtually immovable, right? We kind of fused it together. But you'll see if you look on the skull, especially on page 127, you can see those lines on the back of the skull. There's like one little kind of mountain shape and then one that's going right down the center of the head, right? That's where those bones used to be separated. Now they have fused, right? That's called a synarthrotic. They are essentially immovable, meaning that if there's probably enough compression, they'd give a little bow. But by and large, if we really flex our face muscles and our skull muscles, we can't move those bones. I don't have temporal flaps that I can move. Okay. Go ahead and highlight synarthritic joints. And then we have amphiarthritic, or amphi. I always say amphi because I don't know, it's how I've always said it. But it's amphiarthritic. And they have limited motion. So examples are the symphysis of the pubis. That is where the two sides of the pubis meet, right? And if you think of a woman giving birth, that pelvis has to be able to, flex a little bit, right? But it's not like a butterfly, just enough movement to kind of move things around so the baby can be removed from the womb, right? Sounds like fun. So that's amphiarthritic. Now we see diarthritic. Diarthritic joints are freely movable. The articulating ends of bones that meet at these joints are covered with the hyaline cartilage that we talked about earlier. We're calling that cartilage articular cartilage. These joints may be referred to as diathrosis. A strong fibrous joint capsule surrounds the joint and is firmly attached to both bones. The outside of the capsule is constructed of ligaments that attach to bones. The inner surface or lining of the capsule consists of synovial membrane. This is an important term. Go ahead and highlight that. Synovial membrane, which secretes synovial fluid, that lubricates the joint surface. Right? You ever have a crane neck lamp and you go and try and put it in place? And, we'd all sound like the Tin Man if we didn't have our synovial membrane giving us synovial fluid. And we went, keeps us from being stiff like the Tin Man. Makes everything articulating and moving smoother and fluid. Diarthritic joints have a variety of shapes and are capable of several kinds of movement. Pivot movement, as in turning the head. Saddle movement, as in the thumb. Ball and socket movement, as in the hip. And hinge movement, as in the knees. Right? Some of these, their name lends to where they are. So moving on to the structural classification of joints. Besides the functional classifications of joints, as discussed, joints are also classified according to their structure, right? So we couldn't stop at synoarthritic, amphiarthritic, and diarthritic. We've got to go in deeper because there's different types. So the structural classification of joints is based on the type of fibrous tissue that holds the joint together and the amount and quality of space between the articulating bones. Go ahead and highlight this. Joints with no space that are held together by fibrous connective tissue are fibrous joints. All right? So if they're connected by fibrous tissue, fibrous joints. You're going to see a theme here in a second. Continue highlighting. Joints held together with cartilage with no joint activity are cartilaginous joints. Ooh, cartilage, cartilaginous, hello. Now we have synovial joints, do have a joint cavity, and that is surrounded by an articular capsule. There's a lot of terminology in this section. Flashcards will be helpful. So immovable joints, synarthrosis, and slightly movable joints, amphiarthrosis, are fibrous or cartilaginous. Its distinguishing factor in freely movable joints or diarthrosis is they are synovial. Oh, here's a better picture of those sutures. On page 128, you'll see the skull. And those lines on the skull, that's the sutures. I just love the human body. It's so cool. All right, so let's talk about cartilage and ligaments. Cartilage, also called gristle, although I've never heard a doctor say you got some gristle going on, is a firm, tough, elastic substance similar to bone, but without its mineral content. Right? It's important. Cartilage serves the following purposes: to cushion bones at the joints, prevents jarring between bones in motion, such as walking. Right? If we think of the pressure of gravity on us, coming down on our weight plus gravity, coming down on those bones, if we didn't have cartilage there, and it would clack, 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 be painful. Right? Number 3, gives shape to external features such as the nose and the ears. So cartilage, from probably about here down, cartilage of the nose. Each of the 3 types of cartilage has slightly different makeup depending on the structural role. So, number 1, highlight this. Hyaline cartilage. This is the most common, often called articular cartilage. caps the articulating surfaces of the bone in synovial joints. And continue highlighting. Fibrocartilage contains a greater density of collagen fibers, is the toughest form of cartilage, and forms amphiarthritic cartilaginous joints such as the pubic symphysis of the pelvis and the intervertebral discs of the spine. So we see in that description there, high density of collagen fibers, and we see the word fibro in the beginning of the word. Fibrocartilage. So that's going to tell you there's more fibers. All right, and so we talked about that pubic symphysis, where the pelvic sides of the pelvic structure meet. Right, so it's a stronger connection, still has movement, but it's not a loose movement. Otherwise, we'd all walk like this because we couldn't keep our pelvis straight. So number 3, highlight this. Elastic cartilage has a higher proportion of elastin fibers, makes it more flexible, and is found in the structure of external ear. That's why, comparatively, this still being cartilage, we can bend and move our ears, although not completely comfortable, but doable. All right. Let's talk about ligaments now. Ligaments are bands or sheets of fibrous tissue that connect bone to bone. Remember that, bone to bone. And help support bones at the joints, such as the wrist and ankle. Then we have bursa. They are fibrous sacs lined with synovial membrane and lubricated with synovial fluid. The purpose of the bursa, lost my place, is to function as a slippery cushion in areas where pressure is exerted, such as between bones and overlying muscle, tendon, or skin. Injury to bursa can cause inflammation and swelling, called bursitis. Sometimes people will have bursitis and it'll be bulging out of the area in which it's supposed to be contained. In a joint, if it's bulging out of the area it's contained in, now parts of that structure that are closer together have bursa bulged into it, and it could be pinching the bursa, right? So that would equate to pain. I mean, anytime we see inflammation, we're going to see pain. All right. The synovial fluid is lubricating fluid produced by the synovial membrane, the function of which is to prevent friction within the bursa and joint capsules. Right, so we want a smooth glide, right? I really wanted to say Slytherin membrane. Watched Harry Potter last night. Okay. Let's look at this table. There's a couple things I want you to highlight here. So we see on table 5.6 on page 129, we see our type, classification, description, and example. So what I want you to do is highlight suture. Its classification is immovable fibrous. Description, bones separated by a thin fibrous layer. They are found only in the sutures of the skull. Go ahead and highlight that. And you can see that in figure 537. And then my favorite anatomical word, and I don't know why, I just love it. Agomposis It's an immovable fibrous joint. Cone-shaped peg fits in the socket connecting bones with the periodontal ligament. Found in the roots in mandible and maximal. Roots of teeth, excuse me, in mandible and maxilla. Just love that word, it's so fun. Next, we see synchondrosis, immovable cartilaginous. So we see that word within synchondrosis, con, that's going to be having to do with cartilage. Thinking back to your little medical terminology, telling you what it's having to do with, there's always clues in anatomical terms. All right, the connecting material is hyaline cartilage, and it's the junction between the epiphysis and the diaphysis of growing long bones. Then we have syndesmosis, slightly movable fibrous, bones held together with dense fibrous tissue. And that is the distal ends, closer to your ankle, of the fibula and tibia. Okay. Go ahead and highlight symphysis, slightly movable and cartilaginous, connected by a flat disc of fibrocartilage. A fibrocartilage means there's more fibers in it of collagen. And that is displayed in the symphysis of the pubis and the intervertebral joints. Go ahead and highlight pivot, a freely movable synovial joint. So rounded bones rotate in a ring made of bone and ligament. So that is an example. The example of that is a joint at proximal ends of the radius and ulna. Right, so proximal is going to be closer to the midline. And the joint between the axis and atlas, and that's going to be in your cervical spine. Okay. Then we see hinge, not just an app. It is a freely movable synovial joint, allows movement only in one plane. That's either flexion or extension. Right, so we have elbow, knee, interphalangeal joints. Next, go ahead and highlight ball and socket. That is freely movable synovial joint. A ball-like surface fits into a cup-like socket, right? We have this kind of movement, well, except without a wrist. And we'll see that in the hip and shoulder joint. So if we were to take off all my skin, look how much movement a ball and socket joint has. Can't do this with my leg. Now, they are the same. I'm sure there's someone that can move their hip joint the same way I can move my shoulder joint. Not me, though. All right. Then we have gliding, freely movable synovial joint. It's a flat articulating surfaces, and that's your intertarsal or intercarpal joint. Saddle, freely movable synovial. Two saddle-shaped bones fit together. The joint between the thumb metacarpal and wrist carpal, the trapezium. And you'll learn the carpals of the wrist, but it's articulating with that particular one. So, well, that's the saddle. Then we have a condyloid ellipsoid, excuse me. freely movable synovial, and is a oval-shaped condyle, fits into an ellipsoidal socket. Joints between carpals and radius. So we're looking at my hand. The pinky side is going to be our ulna. Thumb side is going to be our radius, right? And our wrist is our carpals. So where the radius and the carpals articulate, that's our condyloid ellipsoid. Any questions about types of joints? Perfect. All right, types of movable joints. So we just went over those in this. There's a couple highlights here I want you to get to. So the various types of movable joints found in the human body are classified as follows. Go ahead and highlight. Pivot joints have an extension on one bone that rotates in relation to the bone with which it articulates, such as in the neck between the atlas and axis, or between the radius and ulna at the distal, just distal to the elbow. So, distal to the elbow. Whoop, here. So they're pivoting. I really want to yell it like Ross from Friends, but I won't. Then we have hinge joints, move through one plane only, such as elbows, knees, two distal joints of the fingers. Then we have ball and socket joints. Go ahead and highlight that. Permit the greatest range of motion. I showed that earlier with my shoulders. I can move so much. If you could see my legs, I'm moving my hip quite a bit, not as much as my shoulder, but quite a bit, more than most. Then we have gliding joints, have nearly flat surfaces that glide across one another, such as spine, carpal, or tarsal. And when we get you in here with Skinny, our little bone man, you'll be able to articulate and move him and just see exactly how the body's moving when there's no skin involved. Kind of need Skinny to do that. Then we have saddle joints. Go ahead and highlight that. Saddle joints involve bones with concave articulating surfaces such as the thumb. Right. And finally, condyloid, ellipsoid, or ellipsoid joints have an oval-shaped end of one bone that articulates with an ellipsoid basin of another, such as between the distal ends of the radius and the trapezium at the wrist. So in the figure above, you'll see types of joints, and they've gone ahead and kind of gave like a machined version of what that joint would look like if we were robots. So we see the hinge, we see that concave area that the convex area fits into, works like a hinge, right? And those are uniaxial. Right, the condyloid or ellipsoidal, we see those two pieces, one kind of bows out, the other fits into it, right? Then we have multi-axial joints. Now what they're pointing to here is where part of the process comes down and allows us to, we'll hit a stopping point eventually in our spine because we'll meet the transverse process, right? But it allows the spine to slide into place, back and forth. All right, let's see here. Before we move on to skeletal and joint disorders, do we need to backtrack from anything? Anybody? Any questions? Cool. So, name skeletal and joint disorders. Fractures. Sure. Oops. You guys have heard of fractures. Go ahead and highlight this. A fracture is a break or rupture in a bone. There are several types of fractures classified according to the severity of the injury. We have simple or closed, compound or open, green stick or incomplete, comminuted, and compression. Now, if you look over in the upper right-hand corner of page 131, it gives you an example of each of picture description. So the incomplete, gosh, that's a small picture. If we look at it, it's not all the way through the bone. It's pretty far in. A large portion of it's definitely broken, fractured, but it hasn't snapped, right? So that's incomplete or green stick. Then we have closed or simple. That's that same incomplete or green stick, but it made it all the way through, right? But they stayed in place, right? So it didn't and come out the skin. Just, I'm broken, now I have a line in my bone where I shouldn't be. So open or compound is the next one, and you could see that where the bone's broken and no longer touching, right? So they'll have to move everything back in place and then set it, let those bones heal back together. And then comminuted, that's where we're gonna see like fragments of bone within the fracture, not just one break. Okay, so they're gonna have to go in and fish out pieces and put pieces, the large pieces back and kind of reconstruct and hope everything can glue itself back together again as it heals. All right, so we got that highlight of the first sentence there, talking about the types of fractures. So fractures are relatively easy to identify. There's going to be pain. Usually the result of a traumatic event. Fractures are painful and limit the function of the associated movement. We're going to break a bone, we're going to have some inflammation, we're going to limit, they're going to start guarding and holding. Usually something traumatic happened, a fall, a car accident. If they've got osteoporosis, some of it can just be from stepping down wrong off of a curb because they're more brittle. Decisive diagnosis is verified by X-ray or magnetic resonance imaging, otherwise known as MRI. Fractured bones usually heal completely after a procedure known as reduction, where the bones are aligned, immobilized by either cast or surgically implanted pins, plates, and screws. So it depends on the severity of the break or fracture, on whether they just push everything back together, and they'll throw a cast around it and immobilize it so that it can heal properly. If it's more complex, they're going to need to go in and pin it in place. Sometimes those pins are later removed. I'm not a doctor. Sometimes they heal and the bone structure is strong enough to support itself again. Sometimes that hardware stays in the body because that bone is so delicate and now so stressed that it needs the metal structures to keep it in place forever now. Where do we go? Oh, massage is contraindicated. Now, I don't know if this contraindicated is a word you guys have come across yet. No? Contraindicated is going to mean not indicated, right? So massage is contraindicated for acute fractures. Acute meaning they just happened. You know, they're still healing. We're going to need a little time between. And the fractures have not been set and immobilized. In subacute stage, massage to encourage circulation and reduce edema is appropriate around fractures that have been stabilized. Massage can also help balance the developing compensation patterns that accompany the restricted movement caused by the fracture. So if someone's on crutches because they broke their leg, you're going to want to address full body because you have to walk in a whole new gait pattern to function on crutches. Plus, crutches haven't changed much in 150 years. They've got their shoulders all the way up here, and they're trying to balance and really create some issues in addition to, plus I have a broken leg. You always want to err on the side of caution, as you might need permission from the client's attending physician first. So if they're in a joint, if they're in a cast, you just want to get the history, document. Make sure you get a clearance from their doctor. It's okay that you get massage. CYA. Always get extra documentation. Even if you don't think you'll ever need it, get it. Okay. Any questions about fractures? Nope. Dislocation. Dislocation occurs when a bone is displaced from a joint, within a joint, excuse me. Go ahead and highlight that sentence there. This is usually due to a traumatic injury that stretches or tears the ligaments or other soft tissues around the joints and requires reduction. You learn that's realigning the bones. And rest while the ligaments heal. Symptoms of dislocation include a loss of contour of the joint and loss of function. Massage is contraindicated during the acute phase. During the subacute phase, massage can be used to reduce scar tissue and address splinting or spasming muscles related to the formerly dislocated joint. Avoid traction and avoid traction and joint movements that may re-injure the vulnerable joint. So what has happened is the structures that were there to hold the joint in have stretched beyond capacity, and that bone came on out of, I'm using his shoulder as an example because it's a pretty accessible. So we wouldn't want to do traction on them again because these are already stretched, and even though they may have healed and that person has a functioning joint again, they're still going to be vulnerable to dislocation again. So doing traction and pulling out on someone where these are already weakened is not going to be a good idea. That's why you do your medical histories and get documentation so you know things like that, so you don't start doing traction on someone who's had a dislocated shoulder and go, oops, I didn't know. Because the board, they don't care. You should have known. It was your due diligence to know. All right, a herniated disc. Go ahead and start highlighting here. A herniated disc is a weakening of the intervertebral disc that results of the nucleus pulpeus or annulus fibrous disc in the vertebral canal, potentially compressing the spinal nerve or root of the spinal cord. I hope you'll forgive my rudimentary drawing. I may have drawn that too small. Is that too tiny? All right, so if we look at these two black structures here, those are representing our vertebrae. When we have some form of compression, whether that be from trauma or gravity from life, just years and years of it pushing down on us, you know how older people, they shrink, that's gravity taking hold, pressing everything. We're going to add pressure to the intervertebral disc. So when you have that pressure, it can't go up, it can't go down, it's gonna go out, either direction. Now, between the intervertebral or column, you have nerves coming out from the spinal column. Now, if you take your bones and squish down and send your disc out further, you're going to start to pinch nerves. And that's going to lead to a whole host of problems. As intended. Right? Does that make sense to everyone? I know my picture was teeny tiny. I can draw it bigger if you'd like. Okay. There we go. Keeps jumping around. Okay. Herniated discs usually occur in the lumbar or cervical spine. That's cervical, lumbar, low back. Symptoms include neck or back pain, numbness, tingling, or pain down the limb of the impinged nerves. So if we're compressing the signals in those nerves aren't being sent properly. If they're taking a hole that they're supposed to go through, or tube, and we're just making it a little smaller. And so we're not getting adequate signal. A client with a suspected herniated disc should be referred to a physician for definite diagnosis by X-ray, myelogram, or MRI, because similar symptoms can be caused by other conditions such as ligament damage, spondylosis, or bone cancer, all of which require very different treatments. So if you're unsure, always err on the side of caution and send them to the doctor. Now, if someone came in and heard that from you, some people might be upset by it, but it's your license and it's your duty to protect them. So you want to make sure that you are doing just that. If you're unsure of it, sorry, I'm going to need a doctor's note before we proceed. It might tick some people off, but it saves everybody a lot of trouble in the long run. Successful treatment for herniated discs involves reducing the protrusion. So instead of having it bulging out, it has room to exist back in its former home, right? Preferably by reabsorption of the nucleus pulposus, into the disc and healing of the annulus fibrosus. This can be accomplished with therapies such as chiropractic or osteopathic manipulations, traction, strict bed rest. These are all going to depend on the severity of the protrusion. Physical therapy or special exercises done with the intention of strengthening the core muscles and creating more space for the disc to heal. So if we can eliminate that compression somehow between the intervertebral discs and let it go back to its home, let it heal, strengthen all those muscles that support that structure, they can go on and lead a normal life that's relatively pain-free. If unsuccessful, or if the disc is putting severe pressure on spinal cord or spinal nerves, surgical intervention might be required. So sometimes too little, too late. they've lived with this pain and they've known what it is and they didn't do personally their due diligence to mitigate it. And so they've deteriorated it so much that they need surgical intervention. And so that's why we don't know how long they've had this pain, how long they've been dealing with it. That's why we want to send them to a physician. They've got a bigger license than we do. Massage is not recommended during an acute episode of a herniated disc. After a definitive diagnosis and initial treatment, as part of a team approach, massage may be helpful to address muscle spasms, referred pain, and compensation patterns that accompany the condition. So the body has an amazing way of, when it's hurt somewhere, the rest of the body compensates to keep on moving down the line. So you see that when people, like when grandma gets up from her chair and she's up, but she's not up. She steps for a little bit before she finally becomes upright, right? That's a compensation she's created to keep her out of pain while she gets up and out of a chair, right? The body has an amazing way to do that. You can watch people gait analysis while people walk down the hallway, and you'll say, well, does your right hip hurt? Because I noticed your foot kind of steps out to the side when you take a step. I mean, it's amazing what you'll be able to realize how the body compensates. That all has to do with our articulations and muscles. All right. Any questions about herniated discs? Oh, sorry, I didn't see these over here. That makes sense. Cool. Okay, moving on to sprains. I want you to go ahead and highlight this. A sprain is an injury to a joint that results in stretching or tearing of the ligaments, but is not severe enough to cause dislocation. Sprains are classified according to their severity. So a class 1 sprain, go and highlight. There is a stretch in the ligament, some discomfort, and minimal loss of function. Then we have a class 2 sprain. The ligament is torn with some loss of function, discoloration from tissue damage, and bleeding might be present. Highlight that. And a class 3 sprain, highlight this. The most severe sprain in which ligaments are torn and there is internal bleeding and severe loss of function. All classes of sprain cause swelling and require rest and support while the tissues heal. So that's where you're going to see people in a sling. We're going to immobilize it, let it heal, but you might not have a cast present, right? It's the ligaments, it's not bone. Sprains cause inflammation. That's pain, heat, redness, and swelling as a result of the tissue damage, plus a painful loss of function in associated joint. So think of the joints that are affected, or the ligaments that are affected. Now that joint is going to have the limitation in movement. Passive movement of the joint that stretches the sprained ligaments causes pain. Okay. So just because I'm moving over here doesn't mean that structures over here aren't activated. So there we go with our compensation again. We're going to learn how to do things to avoid pain. That's just the human condition. Massage is contraindicated during the acute phase of the sprain. When signs of inflammation are present, massage is appropriate during the subacute sprain, and the healing stages to help reduce adhesions, edema, and stiffness while enhancing circulation and flexibility. Right. So, talked about this just a little bit ago. Grandma gets up from the chair. She's hunched over, right? We can see that in that little diagram on page 132. Rheumatoid arthritis can progress into disfigurement of the joints and hands. And then we see, here, wait a second, our normal posture and then advanced ankylosing spondylitis. So let's talk about arthritis. Go ahead and highlight this. Arthritis is an inflammatory condition of the joints, often accompanied by pain and changes of bone structure. There are many kinds of arthritis. The most common are rheumatoid. Sorry, I've got a tickle. Rheumatoid arthritis, osteoarthritis, and gouty arthritis. So go ahead and highlight this. Rheumatoid arthritis is a chronic, systemic, autoimmune inflammatory disease and is most serious and crippling form of arthritis. So when you see the words rheumatoid arthritis, it's systemic, right? It's not just the fingers. It's not just the, it's not one joint. It's the whole body. Their joints are basically under attack. And it's autoimmune. So it's the body doing it to itself, right? So end highlight. It is a systemic disease often involving several joints. The first effects of synovial membrane that line joints, so we lose that lubrication, right? And then deteriorates from there. The joints become swollen, hot, and red. The inflammation causes the articular cartilage to erode and the joints to calcify. And eventually they become immovable. Its cause is unknown, but treatments are available to slow the progress and reduce discomfort. Massage is contraindicated in the acute stage because it aggravates the condition. In the remission stage, gentle massage and joint movement well within the pain tolerance can be beneficial. Right, so we want to make sure very gentle, caring massage. It's the power of touch can do a lot of things. All right, let's see what we're doing on time. Okay, osteoarthritis. Now we can go back, medical terminology, osteo, bones, we're talking about bones, is a chronic disease that accompanies aging. It usually affects synovial joints that have experienced much wear and tear or trauma. Go ahead and end highlight. The knees, hips, and spine are common sites for this degenerative disease, which erode the articular cartilage and results in abnormal bone thickening and progressive joint immobility. Arthritic pain can come and go and ranges from mild to unbearable. In the acute inflammatory stage, the affected joint can be swollen, hot, and painful. In the subacute stage, the pain in the joint subsides somewhat, but there's noticeable stiffness. There is no cure for osteoarthritis, but medication, exercise, and massage help relieve pain and maintain mobility. Surgery is sometimes indicated to remove spurs. So those are little projections of bone that are penetrating into soft tissues usually. Or replace affected joints. So we get our bionic grandma and grandpa with their titanium hips. You know, that's what I always say when they come in. Oh, I got a new hip. I say, you're bionic now. Massage is contraindicated during the inflammatory acute stages of osteoarthritis, but is indicated during subacute stages to help relax related muscle tension, reduce pain, and maintain flexibility. I want you to go ahead and highlight this. Spondylosis is an osteoarthritis of the spine that can affect the cervical, lumbar, or thoracic vertebrae. It is characterized by the degeneration of the intervertebral discs and formation of bony growths on the vertebrae called osteophytes or bone spurs. Spondylosis is slow progressing degenerative condition that affects middle-aged to elderly people. There might be no symptoms until osteophytes grow enough to put pressure on a spinal nerve, the spinal cord, or begin to limit movement between the vertebrae. Gentle exercise and movement can help slow the progression of disease. Massage may be appropriate with caution and in cooperation with the primary care provider. All right. Gout. Gout, also referred to as acute gouty arthritis, is caused by a high concentration of uric acid in the blood that precipitates out into the interstitial and synovial spaces in the form of sharp, needle-like crystals. Sounds fun. Right? Anything needle-like where it's not supposed to be doesn't sound like a good time to me. Uric acid is a metabolic byproduct of purine and is normally excreted from the body by the kidneys. High blood levels of uric acid, or hyperuricemia, can result from eating foods high in purine, such as shellfish, red meat, organ meats, lentils, or consuming high amounts of alcohol, which interferes with the kidney's ability to eliminate the uric acid. So you're eating the normal amount, but your kidney function is disrupted. Or because of low functioning kidneys, which is sometimes just a physiological happening. Go ahead and highlight this. The most common place for the crystals to settle is the phalangeal, metaphalangeal joint of the large toe, where an immune system response to the presence of uric acid crystals cause classic inflammatory symptoms of pain, swelling, heat, and redness. Other joints can be affected by gout, including the ankle, knee, fingers, wrists, and elbow. Attacks usually last a few days and subside on their own. Over time, attacks can become more frequent and severe. Uric acid crystals can also cause kidney stones. Gout can be an indicator of other medical conditions. So before proceeding with massage, a client with symptoms of gout should receive a medical clearance. In the acute stage, gout is a systemic contraindication for massage. In subacute or remission, it is locally contraindicated. So if they say, I've got gout in my toe, and you've got the proper form from the physician, we're going to avoid the toe, right? Are we noticing a theme here? Always get clearance from a physician if they've got something going on, right? CYA. Let's talk about ankylosing spondylitis. Ankylosing spondylitis is an inflammatory arthritis that targets the sacroiliac joint and the spinal articulations, including ribs, although it can affect other areas of the body, such as shoulders, hips, and small joints of the hands and feet. Where'd I go? Oh, sometimes the eyes become involved, and rarely the lungs and heart can be affected. It is a genetic autoimmune disease and primarily affects men between the ages of 15 and 35. Chronic ankylosing spondylitis begins with stiffness and pain in the low back and hips, then progresses up the back and neck. In severe cases, bone formation leads to spinal and vertebrocostal fusion, leaving the body in a forward stooping posture and the rib cage frozen, which compromises breathing. Like I said earlier, when you take those deep inhalations, Your rib cage expands, right, to accommodate the bulk in your lungs now. Currently, there is no cure, but medications and proper treatments help slow the progression and reduce symptoms. Anti-inflammatory drugs and proper exercise are essential to reduce pain and maintain posture and flexibility. As with other inflammatory conditions, massage is contraindicated during the subacute stages of ankylosing spondylitis. The appropriateness of massage during the subacute remission stages has not been determined and must be decided on a case-by-case basis in cooperation with the client's physician. Send him to the physician. Bursitis is an inflammation of small fluid-filled sacs, bursa, located near the joints that reduce the friction of overlying structures during the movement. Talked about this a little bit ago. There are more than 150 bursa in the body, located between moving structures such as bones, muscles, skin, and tendons. Bursa act as a cushion to allow smooth gliding between these structures. Bursitis is a painful condition that results from repeated irritation or trauma. The most common site of bursitis is subdeltoid bursa of the shoulder joint, but it can develop at any joint. Pain from an acute case of bursitis drastically limits joint mobility. After the inflammation subsides, mobility remains limited because of pain and contracted muscles. Massage is locally contraindicated during the acute stage of bursitis. However, in the subacute stage, mild exercise, range of motion, and massage are effective for restoring mobility. Now we have osteoporosis, probably something that everybody's heard about. Osteoporosis means increased porosity of bones. It says it right there in the name, bone, porous. Osteoporosis affects 4 times as many women as men, and its prevalence increases with age. Until around the age of 35, by storing various minerals, mostly calcium. After that, it begins to slowly demineralize, increasing the risk of osteoporosis. Risk factors that play a part in development of osteoporosis are aging, genetics, having a small bone structure, like a diminutive structure, smoking, alcohol abuse, and a sedentary lifestyle. So exercise is going to strengthen, moving the body strengthens the bone, right? Osteoporosis is a silent disease because there are no apparent symptoms. Often the first indicator is a fracture after a minor incident. So something that wouldn't have normally fractured the bone, right? And they go, that's weird, you're 48 and you stepped off a curb strangely. And now you have this fracture, right? So that's where they would go, maybe you have osteoporosis. A definitive diagnosis is done with a mineral indicator, mineral density test, and X-ray studies. The best treatment for osteoporosis is prevention through good nutrition with ample amounts of calcium and vitamin D. You need those 2 to work together to mineralize the body. And regular weight-bearing exercise throughout our life. So a little bit, pick up some fibers, and do some weight-bearing exercise. Increased reabsorption of calcium into the bloodstream causes thinning of bone tissue, leaving it more fragile and prone to fracture, especially where bones are weight-bearing, such as the spine and pelvis. Because we have to think about, not only does the spine and pelvis support our weight, but when you move and gravity and your weight are compounded, they're supporting that much more. When severe osteoporosis is present, the massage therapist must be very cautious, remember, because minor things can cause injury to them because they have porous bones, right? Avoid deep pressure or forceful joint movements that could lead to a possibility of fracture of delicate bones. We're almost there, guys. All right, so spinal curvature. This is also something you're probably familiar with. I want you to go ahead and highlight this first paragraph right after the tealy text, and I'll read it to you. The healthy adult spine has a double S curve when viewed from the side. The cervical and lumbar portions of the spine concave and have normal lordotic curve. The thoracic portion of the spine is convex and has normal kyphotic curve. These curvatures help position the head over the pelvis and improve flexibility, strength, shock absorption, and balance. Sometimes abnormal curvatures of the spine develop. Okay. So, hold on. In some instances, this isn't a highlight. Abnormal curvatures of the spine begin as functional conditions of posture or soft tissues pulling the spine out of alignment. If left untreated, the constant pull of soft tissues or gravity cause vertebrae and other skeletal structures to change shape and become more of structural dysfunction. So we have scoliosis. That's probably the one you're most familiar with, you hear the most about. Is lateral lateral curvature of the spine that involves a rotation of the vertebrae. And you can see that demonstrated in figure 4.2a. You see where we have that deviation, that have the ghosted out portion of the spine where it's supposed to be, and then the deviation of where it has moved to. All right? Then we have lordosis, and it is exaggerated lordotic or concave curve most commonly found in the lumbar spine, creating condition commonly known as swayback. So that's represented in figure B, down the low back there, an extreme curve in the lumbar spine. Then we have kyphosis. It is an abnormally exaggerated kyphotic or convex curve of the thoracic spine. This condition is also termed hyperkyphosis. Postural kyphosis usually becomes apparent during adolescence and is associated with slouching. They're seeing it a lot more with people shrinking down over their phone, right? That's becoming a lot more prevalent. The shoulders back, line everything up. All right. Schauermann's kyphosis is a genetic condition that also becomes apparent during the early teenage years, but tends to be more severe with irregularly formed vertebrae or discs. These abnormal curves can develop because of congenital defect, habitually poor body mechanics, and aging or other reasons that are not easily discernible. Regardless of their origin, these abnormal conditions cause tremendous biomechanical stress on the body. Massage and exercise, although not offering a cure for these conditions, are very effective in counteracting the stress and pain associated with these abnormalities. So sometimes these curvatures can be so severe that they'll go in and have surgical intervention. Most of the time you'll see that it's enough deviation for them to have changed their posture, but not enough to be detriment to their day-to-day function. But with those deviations, you have to recognize that they have to perform certain functions, not all of them, in a different way. But if we look on figure A, we can see her sacrum down there. Instead of being where it's supposed to be, it is tilted. So what do we think it's going to do to the articulating hip bones, right? It's going to kind of hike her up a little bit, which is going to, she's going to have to step down further to get to that leg, and then she's up again, right? So all of those compensations are going to add to aches and pains elsewhere in the body because the body is amazing at compensating. It's rough. When you get into gait analysis and watching people, the way they move, you'll be able to pick it out of a crowd like that. You'll be walking through Walmart and be like, hips too high, that person's shoulders lower. You'll just be able to see it. With the kyphosis, when it has to do with slouching, if you look at the body the way it's supposed to be, that's better. So I want to keep my head above my pelvis. The further I go forward, the more strain of the weight of my head is on all of these structures back here, right? So think about time, years and years and years of that, and then finally you try to correct it. You know, it's Rome wasn't built in a day, right? So you've got to be diligent for ourselves when we're working. These can affect us if we don't use our proper body mechanics. And we'll get into that more when we get in hands-on and the world has been restored to normalcy-ish. But it's important that you protect your body from slouching over and creating that. My grandma always called it the dowager's hump. Little ladies in their grocery carts. All right. Anyway, so that's the skeletal system, guys. I know I prattled on quite a bit. Are there any questions before we go? Any other questions about sheets or anything?
We have to do all these questions, correct, at the end here?
Yes, please. And that's one of the objectives you'll find on your daily sheets that we sent out. Okay. And if you're looking on daily sheets, you'll see a lot of congruence between daily sheet and what's on Mind Tab. We just thought it would be a good way to show you guys how we're tracking you too.
Do you have like a syllabus? Because I don't know until Monday what we're supposed to be doing that week.
I'm not sure if there's a full syllabus. I'd have to email Dave about that.
Okay.
I'll email him and I should get back to you later today, see if we can't have something that just kind of pace you through.
Yeah.
Because it is nice to know before you get the lecture, like glance at what you're going to be learning.
Mm-hmm.
And instead of tuning in and be like, ta, it's Florida Law today.
Right.
Which
I get it.
which questions at the end are we doing? The section questions for discussion and review, or all of that at the end? Because there's
nothing on the sheet that says that we do this, by the way.
okay, so I'm confused. So what are we doing?
134 to 136 is what the sheet says.
What does the sheet say? I don't have it in front of me.
134 to 136.
I would say all of them. And you can write it on paper and just snap a picture of it and upload it to your email and send it in. Or if
Okay.
you want to fill out your book. I know the section questions might be a little bit more writing.
And then do we also have to do the Beck Chapter 5 packet and email that in?
Yes.
Okay.
Yeah, and it should be the skeletal section of chapter 5. You
Okay.
put all the anatomy in one section. All right.
Okay.
Any other questions before we go? Well, thank you for attending. Is it Valeria?
It's Valeria.
Valeria, I'm sorry. I hate butchering people's names.
No, it's all good. Thanks.
All right, and everybody's got real names on there. Cool. We had a couple phone numbers I had to decipher yesterday. All right. So this lecture will be up if we need to go over anything, or if you need to go back over anything. And you can always email me with questions to me and Lorianne. Dave still, he's just been out of the building doing Dean of Sun State things. But he'll still be involved and teaching a little bit as well. So, but you'll be seeing a lot more of me. Bye. All right.
All right. Thank you.
See you guys next week. Have a good weekend.
Two.
All right. How do I stop?